obviously know about end-of-life care and how Patient Online can facilitate and improve some of the aspects of end-of-life care. So these are people here in the room with me. I'm Ralph Sullivan. To my right is Sinead Clark, a GP advisor from Macmillan Cancer Support, and Imran Khan, Clinical Support Fellow, working on the guidance with me. This is fundamentally the approach we take. I'll just give you a second to read this quote from a patient in Manchester. And I think the image captures it. It's not just a matter of saying, what's the matter with you? But it's actually wanting to know what matters to the patient. What are their priorities at the time that you're seeing them? So this is what we hope you will gain from the webinar over the next hour. We're going to talk about how to use Patient Online safely and effectively. The GP record access is absolutely critical, and how you record data in codes can make a big difference to the value of the record to the patient. Of course, there are requirements then for the patient to be able to understand that data and to be able to access it. Health literacy is really, really important. It helps not just to understand the record, but obviously in their end-of-life care, they are more able to make the right decisions for themselves if they understand the issues. And many people towards the end of life, not just for mental capacity, but physical capacity, may be unable to access Patient Online. And we're going to talk a little bit about that later. And underlying this whole process is that of care planning and coordination. This is about looking to prepare for what is going to happen later. And as I talked about, where digital inclusion is an issue, it may well be that families and carers have a very good reason for wanting to have access to Patients Online services. So this is how we're going to run through the program. First of all, introduction, followed by talking more specifically about end of life and how Patient Online is relevant. We're going to talk about care planning and then mention a little bit of the background about how to do all this, and particularly how to share access with family members safely and effectively. Now, as we go along, questions may well come to you. It would be really, really good if you could use the type in your questions. It's the bottom left of the screen, just below the chat. And whilst we're talking about that, it would really help us to have an idea of who you are. Not personally, but what your health role is. So it would be really helpful to us if you would just spend a second to type in your role: GP, nurse, manager, commissioner, Macmillan, hospice, whatever you feel is the most relevant information. It would help us understand who is interested in learning about this topic. So let's move on. Patient Online. There is a whole toolkit of guidance on the RCGP website, which is accessible to anybody. You don't have to be a member of the Royal College. You don't have to be a doctor. It's free, and there's lots of guidance that goes into all the details around Patient Online. So a lot of people already have access to Patient Online services, particularly appointments and prescriptions. 23% of the population in England are registered with their practice for both appointments and repeat prescriptions. Only 4% are registered for access to their record. I'm not going into the reasons for that. You may have your own ideas. What we are going to be talking about mainly is about how record access contributes to end-of-life care. and perhaps why you might think about recommending it to your patients as they enter the end of life stages. So a couple of years ago, college did a survey of people using patient online in practices and saying, tell us what you think about record access. And we had 211 replies, and this is just to give you a feel of what people thought about record access. The pie chart there gives you a breakdown of the role of the people who replied to the survey, and this gives you a picture of the numbers of people who were offering the different levels of record access. All practices in England now are by contract expected to offer detailed coded record. This was a couple of years ago when things were slightly different. Clinical correspondence is one step further. It's optional, and 2 years ago was a minority interest. And this is what people said. And you can see that people wanted that it was felt that a good reason for recommending patient online record access was so people could see test results, could get to understand what's in their record, use that information to manage their conditions, and also a significant number of perhaps 30% of those who replied said it actually supports family and carers. So this is the fundamental set of services: booking and cancelling appointments, ordering repeat prescriptions, which practices are very familiar with now, access to the detailed coded record, and the little graphic there gives you some indication of what's included within the concept of detailed coded record, and the extended record access, which includes things like scanned letters, potentially consultation notes, and free text attached to the codes. And in end-of-life care, this coded information can be really useful. So this can be entered through templates. All the systems, the GP systems, have templates within the structure to help you add the right codes. It encourages the correct codes to be added, which have a clear meaning, and it means you can explain to the patients what codes are there and how to interpret them. And the codes also in the templates are suitable for sharing systems around the country, particularly where the local community has an EPaCCS system up and running. Right, Imran, could I ask you if you would carry on and tell us some more about patient online in end-of-life care?
So basically, patient online can be used in end-of-life care because it gives people the opportunity to use all some of the services that we talked about earlier, ordering the transactional services that we typically think about, which are ordering repeat prescriptions and booking consultations and cancelling consultations. But also these patients often access quite frequently the different services, including general practice. Having this coded information means patients are more informed about their health. They can get more involved in their own health. It leads to them wanting to increase their knowledge, and that thereby increases their health literacy and promotes this idea of a shared decisions and being more involved in their own care. And actually it's empowering them to take a more active role in how they go about managing their care. Obviously, in all these, all the different systems and different vendors have different access to the patient online interface, and these days smartphones and one of the key areas, and all have smartphone access, but there is also a web access to them. I'm not going to go through the different vendors, but all vendors have varying access. And I'm gonna hand over to Sinead to talk to us about what good end of life care involves.
Thank you. So, good end of life care, I'm sure you all have your views on that, everyone who's logged into the webinar, and I'm sure I would have thought we'd all agree with these points. So good end of life care for our patients would be well coordinated, all the different professionals working together, shared decision making, so allowing patients and their relevant others to be part of those decisions as is appropriate and as much as they want to be, and to be properly informed about their choices. Timely information, I think, is very, very important, especially as someone gets near the end of life. Their condition can change very, very quickly, and ideally you want everyone caring for that person to have access to completely up-to-date information as to what's happening to them, and it can literally change hour to hour, that I'm sure you all know and have had experience of. You want personalised care planning, so you want care planning that's relevant for that person, which goes back to what was said about the beginning, Bara. It's what matters to that person, not what's the matter with them. So that's about absolutely personalising it to what that person needs and wants. You want those who are caring for that person or helping them to have access to the information there and then when they need it, not to have to go off and access it separately somewhere else. And you want, as long as that's what the patient wants, you want the family and carers to be involved. And as we know, particularly people who want to be cared for and die at home, their family and their carers are absolutely critical to making that work. And we really need to help support them with information, as well as support them in other ways. So the Royal College of GPs have recently, Catherine Millington-Saunders, who I'm sure a lot of you will know, has worked with Marie Curie and the college to put together some daffodil standards for end-of-life care, particularly around how we should be looking after these people within the community and how general practice should be involved with these people. Very recently launched, but the basic principles are all fit with all the other national documents like Ambitions for End-of-Life Care. Those of you that use gold standard framework in your area will recognise these aims as well. So we want professional and competent staff. We want staff who feel enabled to give the best care they possibly can. We want people to be identified early who would benefit from palliative care and good care planning and coordination. That's normally the biggest advantage, I think, to identifying people as early as possible when they start to near end of life. The daffodil standards have got a lot in them about carer support. Before and after death, it's incredibly important for the patient themselves and for those carers and their resilience and their well-being. Seamless planned coordinated care, I'm sure we'd all admit we want that, and how we use IT is absolutely critical to making that work. It's really, really important. Unique needs of the patient, as we've discussed, it needs to be as personalised as possible. We want quality care, particularly in the last days of life when someone's fluctuating very frequently. Again, that's about having very timely information sharing, and within the context of this webinar. Care after death as well is very important in these standards, and care for the relatives. And the daffodil standards also talk about general practices being hubs in compassionate communities, which is a really, really interesting development that I'm sure some of you on the webinar will be involved in your areas in compassionate communities. And of course that involves multiple organisations helping those patients, including third sector. And we then have the challenges of how information is appropriately shared with everybody who might be involved with that patient. So that again gives us IT challenges. We feel that patient online can be used, particularly with these three standards, can be particularly helpful. The planned coordinated care, which I know we're all striving for, quality care in the last days of life, and this compassionate communities and sharing of information between everyone, including the patient and their loved ones, so that we can fulfil those three aims. So end-of-life care plans can come in lots and lots of different forms. They can be coded within the patient notes. They can also be more sort of qualitative, they can be written, they can be left in the patient's note. But what's really, really important is that they're shared. because otherwise there's no point having a little bit of paper somewhere in your house that no one else has ever seen. It's not going to lead to you as a patient having better coordinated, more seamless care. Care plans, there's lots of different types up there and lots of different ways of doing this, but they tend to have the person's personal details in. Care information, incredibly important there. Their care preferences and choices, and any future care decisions they may want as well. And this will often involve things like DNA CPR if it's been decided the person is not for resuscitation. Some areas around the country will be using a system called EPaCCS. And EPaCCS is just a way of coding this information really, and then sharing it. And there are lots of different systems out there for sharing it. Some systems in our area, we use 2 different systems, EMIS and GraphNet, to code and share this information between as many professionals as possible. I'm sure you out there will be using lots of different systems as well. The point for us and this webinar is to say it's very, very important you code this information out. We all use the same codes. Whatever system we're using, we use the same codes, and we'll all be going over to SNOMAD codes soon, which will standardise this even more. Because if we're all coding this the same way, it allows us to share it between different systems. It allows us to share it with the patient, with patient online access as well, because the information will be coded, it will be easy to see and easy to find. So whatever systems you're using, coding consistently is the absolute key. And this just shows you some of the challenges around what we call EPaCCS, which is really just coding and sharing information for people nearing the end of life. There are lots of different systems out there, as we've alluded to on here. There's lots of different challenges because really to get this right, we need to be able to share information across lots of different professionals and the patient and their relatives, as we're talking about today. And it is a challenge, but it is incredibly important. It's an incredibly important enabler for getting end-of-life care right for our patients. So I think, you know, the more we can do to keep working on getting these systems, IT systems, talking to each other and sharing, I think the better. And I think encouraging the patient and their relatives to be able to access this information, particularly at the end of life, is a really, really important part of the system, and we miss that out at our peril, really. It could possibly be the most important thing that we do, and it's the most enabling for the patient, and it's very, very important for us as professionals, I think. So that slide is really just showing you that some of us are doing EPaCCS, some of us aren't. We'll all be sharing data, and the key is for us all to code it consistently and share it, and that allows the patient and carers to access that information as well. We've talked about the pros and cons of different ways of doing EPaCCS. So if you have a system of EPaCCS where you have a slightly separate system, so data is either uploaded from your clinical systems into another record, or you will enter information into another record. The only problem will be with patient and carer access that we're talking about today. The patients and carers are only seeing what's coded and what's accessible through the GP record. So it's something to bear in mind. You know, as long as your GP record is absolutely up to date, coded properly, then this will work. The patient and carers will be able to see what they need. But it's just something to bear in mind if you do use a very separate EPaCCS record, to think about how you get patient and carer access. And often people have said when we've gone out to them, they don't really want a separate password for their GP system and then a separate password for a separate EPaCCS system. So if you do have 2 separate systems, it's about working. There are solutions that are being looked at out there to let the patient and relatives just have one log on, one password to see all of the relevant information. So that just gives some of the pros and cons as we see them to the different ways of doing that. I'll pass back over to him. Thank you.
Thanks. So I'm just going to go through a scenario. It's a scenario that I put together to illustrate some of the possible benefits to using patient online in the context of some of these more complex systems that Sinead discussed. And when actually that infrastructure isn't in place, or for whatever reason they're not able to access it. So I'm going to go through a patient who is Mrs. EB, who's a 76-year-old lady with COPD. She's been recently diagnosed with bronchocarcinoma. She's living with her daughter currently, is currently for active treatment, and there's no DNAR CPR. in place. And so I'm going to just kind of go through some of the opportunities and some of the ways that you could use patient online to improve care and to hopefully sort of identify with some of the standards of the daffodil standards. But first, one thing I want to point out there is that she's living with her daughter, and this might something that Ralph mentioned earlier about Proxy Access. I think this is a good opportunity to talk about Proxy Access. Proxy Access is basically giving someone else, either a carer or a relative, access to your own patient online information. Well, and that could be the full access, including all those transaction services we were talking about, the coded information. There's this idea of formal versus informal proxy access. Informal being the patient just giving their login details to a relative. Obviously, there are inherent problems with that. It's difficult to audit. It's difficult to identify who's using it and when. And then there's the more formal approach where the patient formally requests that a proxy has access to their patient online, and the level of access would depend on what's set up for that patient or what the patient wants. I'm actually part of a practice that's trialing the proxy access formally. So it's giving an example that we had recently in a practice was separated parents who both wanted access to their children's records, and by giving both sets of parents their own individual access, it's auditable. You've got a level of security there, and you've got a level of quality that you can gain by formalizing the process. There's some guidance on the patient online toolkit about proxy access. Obviously, there are patient safety and opportunities for misuse, and again, that's covered in the toolkits. I'm not going to go through it too much here, but I think importantly, in end of life, we are dealing with a set of patients where capacity implications may be relevant, and often it's useful to identify those capacity implications early by asking about proxy access early. You avoid those sometimes difficult conversations. There are guidelines and processes where you can give proxy access in the patient's best interest, but again, it's more difficult, and there are more risks involved with that. So it's something that worth considering early in any process. I'm going to go through that scenario I talked about earlier. So let me just go back. So this is the lady with bronchocarcinoma. I like to see it as a sort of an iterative sort of cycle. So there are some opportunities initially. So the flags that I put at the top of the screen are an opportunity for any GP or all the practice to identify patient online and the patient online services, including access to the coded record to the patient as even just as a pointer. It's not a huge. It doesn't require a huge change in practice. It's just highlighting that it may be useful. It shouldn't require any additional workload. It shouldn't put any extra pressure. It's just highlighting that it can be useful, and that would extend to things like proxy access when it becomes more widely available. So in our case, it's Mrs. EB. The immediate assumption is that actually this is an end-of-life care setting, or an area where a care plan may be useful. So the GP might produce a care plan, and that's typically done to a set of coded templates, like we suggested earlier. The coded information is entered into the GP record, and at that point, if there's an operational EPaCCS system, then that can be updated, and then at that point, a patient or relative can be offered or prompted to consider the use of patient online services to view the care plan, view the record, and that provides an opportunity for them to be more engaged, like we said before, be more increase their health literacy, be more engaged in their own health and or their own care planning for the future. So that's so that they can view their record, they can see if it's updated, they can look at that to see if they need to prompt further action. I'm just going to go through the scenario a little bit further. So 6 months later, she develops a pleural effusion. She's hospitalized with metastatic disease. They decide there's no further active treatment, and a DNA CPR is completed, and she's discharged from hospital. And often that DNA CPR isn't, for whatever reason, isn't coded, doesn't come through from the hospital in time. So in this case, we'll go back to my feedback cycle. So we know Mrs. EB, there's a DNA CPR required following a hospital stay. This prompts contact with the practice because she may have looked at the information online. She may have looked at her own coded information, which will state actually there's no DNA CPR on her coded record. She can make contact with her practice. She can do that either through traditional means, or she can even use some of the transactional patient online services. She's noted that there's an error, and that can feed back into the GP practice, whether that's through a face-to-face consultation or somebody in the practice able to update that coding to enable the record to be corrected. And throughout this, the patients are aware of what's on her record and their carer. So we'll go through the scenario a little bit further. So Mrs. EB's condition deteriorates. Her daughter orders repeat prescriptions, and she can view the GP record online. She's looked at the record. She's seen that DNA CPR is recorded, but she notices that her mother is still for full escalation of care, which she understands and has decided along with her mother she no longer wants. So again, if we go back through this patient cycle again, that proxy, in this case is her daughter, looks at the coded information on the GP system. The error is identified, or rather an update in preference is required. She makes further contact with the practice to update it, and she can either arrange a telephone consultation or face-to-face consultation, and that preference for care is coded. And if there's an EPaCCS system in operation, that would automatically be forwarded to the relevant system itself. This is just an overview of how, if there is an operational EPaCCS system, where patient online fits in. And as you can see towards the bottom of the page, both Mrs. B and her proxy, her daughter, have access to patient online and all the data that's held by the general practice. So that's all their coded information, not just some of the information that's pulled through into this much more complex EPaCCS system. It's useful to realize that actually all that information is available and accessible to Mrs. EB and her proxy, regardless of that EPaCCS system. So actually their view of their coded information doesn't change. So I'm going to talk about exactly the same case, but without having that complex EPaCCS system, whether that's through organizational difficulties, whether that's because the system's not in place yet, or it's being brought forward. So exactly the same scenario. She's a 76-year-old lady with mild COPD, diagnosed with bronchocarcinoma, living with her daughter on active treatment, and no DNA CPR is in place. Sorry, and actually it's exactly the same process. The only thing that changes is actually that the coded information is not transferred to an external system. The actual interaction with the patient and their view of their coded data, because a care plan would still be useful for this patient. So you would still develop a care plan. How you'd go about using that might be slightly different depending on where you are. But all that information is still coded. They can still view it through the patient online interface. They can still look at whether it's up to date and if there are any errors, and then they can still be prompted to go back to the practice to see if it needs updating. Throughout this, we've talked about sharing this information and how patients share this information. And often it's overlooked, but all of the current GP practices and the GP system vendors have a method of sharing that online access in either a formal or informal way. So in this case, if for example, the patient went to A&E unexpectedly or to an A&E out of area where all the information wasn't being held, or even abroad, they could log in through their own device where there's a smartphone, and they could share visibly on the screen what was on their actual patient online record. And they could just simply give that to the clinician or the health professional looking at the information, and they could do it that way. It's a much more informal method, but it gives people full access to, if all information is coded correctly, give them access to all the information they normally have access to, their repeat medications, their allergies, that sort of information that might be useful in an acute or end-of-life setting even. The other method, which is a more formal method, is where you use the device or the system, the vendor's system. I'm not going to go into particular vendors, how particular vendors do it, but some of the vendors give special codes so that they can give these codes to the clinician, and they can log into their online record more formally, and they can look at it on a screen in A&E, for example. So I'm going to pass you back to Ralph.
Thank you. Thank you very much, Sinead and Imran, for a very interesting, I hope you found it interesting, discussion of end-of-life care and where information flows to the patient fit in. I think the key message that we want to give is that patients being able to see their record involves them in their care, enables them to more clearly express their preferences, and helps us as their healthcare professionals to provide better care. We're not just producing this webinar to support end-of-life care. I'll just give you a little bit of information. We're going to be providing a set of documents that go into more detail than we've been able to do in this webinar. And those will be available on the patient online toolkit, which you can get to through the RCGP website. There's already a lot of information, background information on things like registering patients' families for Proxy Access, the questions of how do you manage with a patient who's not got the capacity to make a decision but would benefit, how do you manage access for parents, and many of the other more complicated things that you may find that you need a solution to. Have a look at the Patient Online Toolkit. This is one of a series of webinars that we're producing. We also have already produced one on diabetes. We're going to be working on dementia and arthritis as other examples of where long-term condition care can be improved by the use of Patient Online. And we're working closely with experts and organizations in these fields to produce the right guidance. So, yeah, in summary, we've talked about the role that Patient Online plays, in particular record access in end-of-life care, how patients' access to high-quality coded information enables them to understand their condition, to ensure that their records are a clear representation of their priorities, and it means that consultations focus on what matters to the patient, not just what matters to the health professional. It complements EPaCCS systems. EPaCCS systems are designed for access to the record for healthcare professionals that are providing individual care to the patient across a health economy. Patient Online allows the patients to see the same information and has got the advantage that many of these patients have actually fairly complex medical backgrounds, with multimorbidity being an important factor in their care. And of course, Patient Online allows access to the coded information about all their conditions, not just their end-of-life data. And in that sense, it reflects the totality of their health situation. I think you can find that using Patient Online and Record Access is worth getting to use in the practice and recommending to patients at the time when you are thinking that they are entering an end-of-life care, and proactively putting in place the things you need to think about and things the patient needs to think about in order to be able to make full use of it. Well, thank you very much for that. We have now got time for questions. I hope you've been putting questions into the system. One second, let's see. Could I just say, we've actually surprisingly, considering the numbers of people attending, we have very, very few questions. So please, if you have questions, type them in to the little window bottom left of your screen and press send, click on send, and we'll get your questions and we will do our best to answer them. In the meantime, we have something that has been raised in the chat room whilst we've been talking. And now I'll have to read this to make sure I've got the details. Yeah, this is a situation. It's an example of an EPaCCS system that's operating in one area, and only EMIS practices are able to upload the data to the EPaCCS system. The reasons for that, I think, don't matter too much, but of course, Patient Online will give you access. The patients access whatever system. All the GP system suppliers offer Patient Online services. So if you're a practice that is not using the system that the local health community links to EPaCCS, then you have a real alternative in using Patient Online.
Yeah, I'd agree. I think this idea that the patient's got access to their information, they can then choose to give that access to anybody who's caring for them, is quite powerful, really, isn't it? And I think that they do that a lot more in Europe. People carry, discs around with all their data on, or they probably, they probably do it like this now and just do it live into their own systems in Europe as well. But it gives the patient much more ownership, and it means you're not tied down by whatever systems are in all the other providers. As long as your GP system is coded as accurately as you possibly can and kept up to date, and then the patient and their carers have got access to it, they can give access to anyone else they want to then, or show it to people. So it is a possible way of getting around some of those problems you're having in that area. And I know EPaCCS is particularly difficult if you're working in an area where there are different GP systems within your health economy. So I'm very lucky in that all of them, I work in Cheshire, and all of Cheshire, all the GP surgeries, bar one or two, are all on one system. And it does make it a lot simpler. And I think as soon as you start trying to design EPaCCS and you've got GP surgeries using different systems, it's much harder. I really do acknowledge that, but I really think this is one way of, almost getting around that and giving the patients the power to share their data.
We are, in fact, coming up to a time where all GP systems are going to be migrating from a version of the READ codes to SNOMED codes. So currently we have a situation where GP systems are speaking two languages. There's reader version 2 and reader version 3. And sometimes the meaning of codes in different systems is not easily transferable, and it can be quite complicated. When all systems are using the one system, once we've got over that conversion step, then we should be all speaking the same language, and sharing data through EPaCCS systems should be improved. But of course, the other thing I think to say about EPaCCS systems is they're not updated every day, whereas using Patient Online, the patient has access to the data as it is recorded, literally. So there's no lag between something like a DNA CPR being recorded in a GP record and is appearing in an EPaCCS system maybe a week or more later.
Totally.
Patient Online means it's there when it's needed that evening.
Completely up to date. I totally agree with that. I mean, we have trouble with sharing with our GP out of hours services, and we send handovers to them as GP practices. But obviously, you know, you're not sending a different handover every day. And for somebody who's fluctuating, or their needs or preferences is fluctuating very quickly, the only way to really, really know you're doing the right thing is to have access to the real-time data as it is, you know, completely up to date in the GP records. So yeah, and that's what it's good to say.
We've got a couple of questions coming in now, so I could just give some answers to those. First one is, how is Patient Online being organised to show useful information in a meaningful way, e.g. all palliative care codes in one place? That's a really good question. And this, the answer to it is it's not, fundamentally. The system suppliers are expected to provide systems that operate to a given level, and part of the contract is not to put data relating to one condition into one view. I know NHS Digital and who control the contract around GP systems has had a lot of requests for Patient Online, not least from myself, to be able to be configured so that there's a cardiac view, a diabetic view, an end-of-life care view. It seems straightforward, doesn't it? But then we also know how long it takes to get even the GP system we use every day upgraded. But this is definitely something that we need but don't have. Some systems are better than others. Of course, you're not necessarily limited, the patients aren't limited to just using your GP system supplier's system. There is another system out there which is independent of the GP system suppliers, and it's worth looking at the market to see what patients might benefit from. Another question, is it possible to use Patient Online with any system? Imran, is that a straightforward question?
When you mean any system, I assume that's
GP system, I guess.
All GP systems are required as part of the GMS contract to comply and gives a patient online access to the coded information and these transactional services. So all systems should have this operation or this ability in place. So as far as I know, all GP systems have this.
Yeah. There's a good question here. In your experience, is this Patient Online, I think it means, associated with an increase in complaints, for example, unrealistic expectations, such as something documented by a healthcare professional, but the GP could not meet this requirement in a timely manner?
As far as I'm aware, there's not that sort of evidence to say that it's creating more workload. There's these risks, there's these perceived risks, but actually these risks are not being brought out or borne out through day-to-day use of them. It's just something that's more of a perceived risk. Often there are ways to overcome these. Often it's just a communication issue, and quite easily overcome.
I think there's always this concern, isn't there, that if you open up records, and particularly if you open up either consultation notes or particularly hospital letters, that it would appear that there may be an untimely delay in a practice acting on something, that there are fears about patients being dissatisfied because they see something that's not right, or even that they may be cross or angry because they see something that they disagree with. I've not got that condition, doctor. Why have you put that in there? We do address a lot of these questions in detail in the guidance, so I don't want to spend a lot of time talking about it now. But I would say, as Imran said, the actual feedback from practices using Patient Online does not show that these fears are being realized in the real world. I first started offering my patients full record access over 10 years ago, and we have not had negative feedback about it. People are really pleased to have access. They make good use of it, or they just look once and don't come back to it. Depends on their health, depends on their priorities. But nobody has said, why isn't that code there? What does this mean? And then been upset. There is something about always explaining to patients when you give them record access about the limitations of understanding medical terminology. But if you present the patient with the reality of the system, they're actually more pleased to have access than complaining about what they see, far more pleased about access.
And I think it just goes hand in hand with the fact that a lot of hospitals are sending out the hospital letter to the patient as well as the GP. You know, this is becoming more normal. I know it doesn't happen all the time. And occasionally it does. I'm sure those of you that are GPs on the webinar have the patients coming in sometimes and saying, what does this mean on this letter I've been copied into? But then it's an opportunity to actually talk it through with them and like you said, improve their health literacy then, because you can talk through what it does mean. And so it's only the same thing as that really, except they're seeing our data on the hospital letter. It might set up some questions, but it's really interesting to hear from my two colleagues that there don't seem to be negative consequences from that so far. So that's good.
Okay, there's a couple of technical, I would call them technical questions here. There's, with new GDPR regulations coming in, how is proxy access to patient records in either end-of-life care or any other situation being managed with EPaCCS systems? I could talk about Patient Online to start off with. I think the most important thing about access to Patient Online is that the patients are requesting access and giving consent to proxy access. So if you, using a formal proxy access process, give login details to patient A's record to someone else, you would get the patient to fill in a consent form, and there is a standard consent form on the RCGB toolkit. That means that the patient is consenting to whatever use that proxy will make of that access. It's the patient's choice, not the practice. The practice is responsible for the quality of the data, the accuracy, completeness of the data. But actually, Patient Online is an opportunity to improve that accuracy. Patients may spot something that's missing, like an adverse reaction to a drug, something that may have happened when they were registered to previous practice and never got recorded. It's part of an ongoing conversation with the patient, which is all about improving data. There's been no evidence that Patient Online has caused any problems for anybody within the old Data Protection Act, and I understand that there's no reason to imagine that the new Data Protection Act from GDPR will be any more difficult to deal with. This is all being done with patient consent. That's the bottom line. And as far as EPaCCS are concerned,
it's just, I think it's just what you've said really. You're doing it for direct patient care, which is mentioned in the new GDPR. This is about as obviously about direct patient care as anything, isn't it? When someone's getting near the end of life and very complex needs, consent is built into this because the patient won't, want access. If they don't want access, they won't ask for it. So purely by asking for it, they're giving consent to see it. And as you said, there's good systems for making sure that they're only giving access to patients, relatives or carers if they've consented. So as long as we follow that procedure very carefully, in general practice will be fine. And I don't understand that there's any additional concerns about this because it's for direct patient care. I don't think there's anything we need to worry about with GDPR at all.
It makes sense if you're going to link a patient's records to an EPaCCS system as a GP, that you tell the patient about it and seek their consent to do so. Legally, under GDPR, GPs do not process data dependent on patient consent. And this is getting a bit technical. But equally, there is no, under the Data Protection Act, no need for consent to share data with other people who are caring for that patient and providing direct care.
Yeah.
The common law duty of confidentiality is slightly different, and there's implied consent that if you make a referral, if you put data into an EPaCCS system and the patient is allowing it to happen, it's implied that consent is given. This is getting a little bit technical, not the main part of the presentation. Spend no longer on it. We have one more question. So the laptop here that the questions are on has just blanked itself, but it's back. This would be a great idea if we could get formal proxy access set up for nursing homes, but still waiting for this to be delivered for EMIS. Will proxy access be covered in the new RCGP Good Record Keeping Guidelines? Two questions. You take the first one about proxy access in nursing homes, or I can add something to it.
So, obviously, when formal act with regards to EMIS, I was actually talking to an EMIS representative on Monday who was giving me the timeline for their rollout of proxy access, and depending on how well this pilot goes, which is, as far as I'm aware, is going pretty well, they have a date towards the end of May, perhaps beginning of June, to enable it fully for all practices. I can't guarantee that, then you'd have to be in touch with EMIS or your own vendor specifically.
For a little bit of background about nursing homes, the technology is fairly straightforward, and although EMIS hasn't got formal proxy access rolled out, other suppliers do. But the situation is not the technology so much as who do you give the login details to at the nursing home, and that is a people issue. And so do you give it to the manager, who then is the only one who logs on? Do you give it to the nurses, each have a separate log on? What do you do if somebody leaves the nursing home but still knows what the log on is? How is that data security managed by the nursing home? So what matters more than anything else is the level of information governance within the nursing home. And I think the practice probably should be confident that the nursing home in question does and continues to apply the right information governance around patient online before they allow it to happen. And that's in the patient's interest as well as the practice's interest. But if all is working well, it should be perfectly reasonable, and it can clearly be beneficial, not just for end-of-life care, but all healthcare.
Yeah.
Does that sound?
Yeah.
Yeah. Okay. And there's something about summary care record, which has got lost in this discussion about access to data and EPaCCS systems. The summary care record could host information from more than one source, the questioner says. Activating additional information within the SCR allows free text associated with read codes to be displayed. Many data repositories are not configured to show this free text. This isn't really a question, is it? So much as, what is the role of summary care record in end-of-life care, and does it complement or replace any of these systems? I think, unless anybody wants to add.
The thing about the summary care record is, so the thing about most of our EPaCCS systems is they're kind of set up just for our locality, and we've all done it differently. The thing about the summary care record is it is it is national. That's like, I'm not an IT expert, who knows me. But so that is where I think it can add a lot of benefit, particularly if you're being seen outside of your immediate area for health needs. So I see it as complementing EPaCCS really for that reason.
And certainly in Scotland, the emergency system equivalent to the summary care record is much more complex and contains much more information than our standard summary care records, where many practices, many patients do not have any additional material included. And free text with recodes can be really valuable, and you can make that available through Patient Online. If you wish, some practices will do that, some won't, and I think a lot of that comes down to how you feel about the way you as a practice have recorded data. People in the past have added free text to recodes that goes way beyond the read code, and that data is very difficult to audit. It can even include third-party confidential data. For example, a diagnosis and somebody told me about this. You really need to be sure before you give record access, and this is one of the details we haven't talked about, that you've checked the record to make sure there is no information in that record that's confidential to a third party that the patient really hasn't got a right to see. And if that information is there, then the systems, the GP systems, allow you to hide it from the patient. And you may then consider whether you need to change that data or to talk to the person about whom that data applies.
Yeah, that's the challenge with free text. Yeah.
It is a big challenge
really,
with free text compared to coded.
Yeah.
Another question has just come in. We're running right to the wire here. If we wanted to pilot full patient online access with some of our patients on our end-of-life care register, any tips on how to go about this troubleshooting? We're coming right to the end, so I'd say listen to the webinar again, read the guidance when it comes out, and I hope the guidance will give you enough information to do that with confidence. So thank you very much. I think we're just about running out of time. I would just like to mention an event that's occurring in 2 days' time in London. The RCGP, in partnership with Marie Curie, are running an event. It's called Developing General Practice as Hubs Within Compassionate Communities, one of the Daffodil Standards, and it is being organised by the same team that developed the Daffodil Standards. So that's from 9 till 4:30 on Friday, the 18th of May. So finally, I'd just like to say thank you to Sinead and to Imran for joining me, and thank you all for joining the webinar. I hope it's been useful and informative.